Hello. Welcome to another Spotlight the Science, where we get to meet the researchers, the amazing researchers that have received research funding from the American Diabetes Association. My name is Marlon Pragnell, and I'm VP of Research and Science at the ADA. And today we have the pleasure of speaking with Dr. Tracey McLaughlin. Dr. McLaughlin is professor of medicine, focusing on endocrinology, gerontology, and metabolism at Stanford University. And she has a MD from the University of California at San Francisco and a master's in public health from UC Berkeley. She conducts clinical research related to obesity, insulin resistance, diabetes, and cardiovascular disease. And it's a real pleasure to welcome her. Welcome, Dr. McLaughlin.
Thanks, Marlon.
You've published a really nice paper recently, leveraging ADA funding on COVID infection and obesity. Can you tell us a bit about what you found?
Absolutely. And I also would like to comment about that whole process because part of why we were able to do something impactful or meaningful was because we had such a quick turnaround with funding from the ADA right at the beginning of COVID. As all investigators know, it takes a very long time to get funding. I mean, it can take a year to get through the whole process. And this happened within I think about 2 or 3 months. And we were able to start a project which later got NIH funding for finishing it. But what happened was early in the pandemic, it was noted that there was an independent association between obesity and severe COVID outcomes. And at first, people thought it was being mediated through hypertension and diabetes and other associated comorbidities, but it turned out that obesity was an even stronger predictor than diabetes or hypertension. And it panned out in many studies in China, in France, in New York, in Southern California, and it's been shown many, many times. So since I study fat cells and fat tissue and how that links to metabolic disease, thought I should take a look at the fat tissue and whether or not the virus might actually be infecting the fat tissue. And the reason is that I think everybody has heard by now that the spike protein on the SARS-CoV-2 virus binds ACE2, which is the receptor. And that had been published through these large autopsy cohorts to be present in human fat. It was just an RNA signal, not a protein signal, but it was said that that was present in fat. So we had a hypothesis that maybe the fat is expressing the receptor for the virus and it's getting into the fat cells. And fat cells are kind of interesting because you can get inside a fat cell if you're a pathogen and escape immune surveillance. It's like a hiding spot. And parasites can do that. They get in there and stay in there and they can stay in there for a long time. So we didn't know, but I called Catherine Blish, who's an immunologist at Stanford, who's doing a lot of work with the virus in other areas. And she jumped on board. And then I contacted our surgeon. We have two surgeons who work with us, Jack Boyd and Dan Azaguri. And like within a couple of days, I think within 3 days, we harvested fat from a heart during an open heart surgery. And we had fat from around the heart, and we had fat from the chest wall, which is called subcutaneous fat. That's the fat right under the skin. And then we had pericardial fat, which is around the sac that encloses the heart. So we had three different fat depots, and we basically isolated the fat cells and infected them with the SARS-CoV-2 virus in Catherine Blish's lab, which is, it's called a BSL-3 level. It's like for high hazardous um, contaminants or pathogens. So you have to have special training and wear a hazmat suit and all that. But we infected the fat cells, and we also infected the non-fat cells that reside in the fat. So those include immune cells. And we saw an extremely strong signal of infection. And that sort of led to the whole rest of the study, where we spent a whole year getting more details about it. But it turned out that it infected both the fat cells and the macrophages within the fat.
Interesting. So then so it infected both cells. So what are the consequences of that? We hear about when we heard about the COVID, we heard about lung a lot. We heard about pancreas and so on. But now fat. What's the relevance of fat?
Uh,
Obviously, obesity, for example. But
right.
I know in your paper you mentioned kind of this aspect of kind of heart, like the COVID hiding in the fat, for example.
Yeah, I think there are two main things to consider with that. So, number one, the fat could serve as a reservoir for the virus to get in and replicate, so that it's there longer and there's more of it, right? It's just like a reservoir for the virus. And the second possibility is that when the fat gets disturbed, when it gets injured by trauma or if there's a pathogen, it could potentially have an inflammatory response. And I think a lot of people know by now that obesity is a state of subclinical chronic inflammation. It's like low grade inflammation. And there's actually many studies showing that as BMI goes up, circulating markers of inflammation like C reactive protein go up linearly. That's been well documented. So there's circulating markers of inflammation in people who are more obese. And what we've shown and others have shown before is that that may be originating from the fat, because you can see macrophages in the fat, and these macrophages and even the fat cells themselves secrete inflammatory cytokines. So, what's particularly important with COVID is that the fat also surrounds your vital organs. So, if you have fat around the heart, which everybody does, but the more obese you are, the more fat you can have around your heart, and you have fat around your pancreas, you have fat around your kidney, you have fat around the intestines. These vital organs that were getting damaged in COVID are also surrounded by fat. So if the virus were able to get into that fat and stimulate inflammation, it might actually directly have contributed to organ damage.
Wow. So the fat then, so because fat's everywhere in a sense, I mean, especially the obese people surrounding all the organs. So therefore, you have this kind of like like COVID there residing in these cells nearby all these kind of critical organs that could then, in a sense, kind of infect and damage the organs, right?
Yeah, absolutely. So we weren't sure that it was getting into all those places, but when we did even our first study, we harvested cells from, the epicardial fat, which is the fat right around the heart. And at that time, there was a lot of attention on the heart, right? Because a lot of people were getting cardiac complications. And the fat that surrounds the heart has no physical barrier. It's literally right on the muscle and it's right on the coronary arteries. There's no connective tissue sheath that separates it. It's just directly in contact. And we did find not only that the virus gets into the fat cells and replicates, we later showed that that replication in the fat was what we call a productive infection, meaning that the virus is, you could have productive or abortive. Abortive is it's there but it's not doing anything, but productive means it can actually infect other cells. So when it gets into the fat, it replicates and it could then go on to infect additional cells. And what we found in the macrophages is that it stimulated a very marked inflammatory response. And we saw this with an RNA signal, and we also saw it with proteins secreted from those macrophages. And a lot of the proteins that we found secreted were the same ones that other studies have found in the blood of people in the ICU with severe COVID. So we concluded that it does infect fat cells and replicate. And in the macrophages, it drives a pretty dramatic inflammatory response. so that in fact it could be potentiating damage to those vital organs that were surrounded by the fat.
It's interesting. I know we are, that we're starting to see more and more of the COVID pandemic behind us, but then we're hearing about long COVID and this people that are just not getting over their COVID, for example, and kind of having other
Mhm.
issues and so on. And can you comment on that, kind of in terms of your findings?
Right. We haven't studied long COVID yet. We did do, we did an autopsy survey, and another group also did an autopsy survey where we looked at humans who died from COVID, and whether we could detect SARS-CoV-2 in their fat. And the reason I'm bringing it up for long COVID is that some of these patients had been sick for many days by the time they died. And so I feel like our latest might have been only 12 days, but at least it was 12 or something days after acute infection. So the virus appeared to be persisting for some time in the fat. What we really want to do is, and we have an NIH grant to study this, but we haven't gotten very far yet, is to actually check the fat like a month later, and then 3 months later, and then 6 months later, and see if it actually is hiding out in the fat and serving as a reservoir. And possibly that could contribute to long COVID. There is some data suggesting that obesity is associated with long COVID. So, in particular, there's a small study in Italian healthcare workers that showed that a BMI, higher BMI, was associated with incidence of long COVID. And then a very large Veterans Affair cohort in the US with 4,000 people showing the same thing. In that study, they showed the three main predictors of long COVID were age, number of symptoms of, during acute COVID, and BMI. So, so it certainly could be. I don't know if it's through residing in the fat or some other association, but there does appear to be, at least epidemiologically, an association.
Yeah, it's clearly very important research to do, and be interesting to see what the outcomes are there in terms of seeing
Yeah.
whether over long terms, long periods, the fat tissue can kind of harbor these viruses. But I think what this is very interesting is this whole concept of obesity and this idea of inflammation. I think it seems like COVID took it to the extreme in terms of inflammation and obesity. But I understand that people with obesity uh, have higher levels of kind of a low grade inflammation that
Mm-hmm.
kind of propagates kind of the risk of insulin resistance and risk of complications and so on. Can you talk a bit about that in more of the general population, the non-COVID population?
Sure, and I can relate it to COVID too. I mean, so if you take people who are overweight or moderately obese, you can see well, in general, there is a linear association between increasing adiposity, if measured by BMI, and insulin resistance. And insulin resistance, which is often also interchanged with the term metabolic syndrome, refers to a constellation of systemic abnormalities that include a lot of things we saw in COVID. It includes inflammation, hypercoagulability, and something that we call endothelial dysfunction, which means blood vessels don't, they're not as healthy. They can't dilate when needed, and you can be more prone to ischemia, which is when the tissues don't get enough oxygen and blood. So endothelial dysfunction, hypercoagulability, which we really saw in COVID, and inflammation. And those really were the three hallmarks of people with COVID who had really, really high levels of those markers, all three of them. And so, one question is, are the people who were getting these severe COVID responses people who had that metabolic syndrome in the first place or insulin resistance? And they were more prone to an overwhelming adverse response with inflammation and hypercoagulability and endothelial dysfunction. It is possible We don't know right now. I will tell you, we do have data that we presented at the ADA in June, but we haven't published it yet, suggesting that that is the case, that people who are insulin resistant prior to COVID do have not only more acute severity, but also long COVID. So that is a paper we still haven't submitted for review formally, but we will. But even so, just to get at your initial question, if you take people who are overweight or obese, the heavier you are, the more likely you are to have this metabolic disease, including subclinical inflammation. But it really varies. So, for example, if your body mass index is 25 to 30, about 40% have insulin resistance or metabolic syndrome. From 30 to 35, it's about 60%. And over 35, it goes up. I don't think we have exact numbers, but it does go up, maybe to 85%. But there's a lot of variability. So in general, the way I usually explain it is about half of people who are overweight or moderately obese have this underlying insulin resistance, and the other half don't. And the ones who have it are the ones who are really at risk for getting diabetes, hypertension, heart disease, stroke, and even cancer. And that's been shown in prospective studies that have followed people for 14 years, that group, that subset of overweight or obese, is at higher risk for these bad clinical outcomes. So it's really would be really helpful if we can really come up with a way to determine which of our overweight or obese have that, because I think even with COVID, we might target them as well. Make sure they're vaccinated. Maybe they would take Paxlovid or something, or maybe they would be more inclined to try to lose weight. But I think for general obesity related comorbidities, at least metabolic ones, metabolic and vascular ones, and then for COVID, maybe COVID outcomes, we really may be wanting to focus on that subset of people if we can find them.
Mm. Interesting. So what you're saying is that some people, you have healthy obese, but then
Yeah.
you have not healthy obese that are at risk. Are there any kind of indicators or any kind of ways in which you can identify or predict who might go versus one path versus the other?
Well, yes, there are. So anybody who's pre-diabetic is probably insulin resistant. So if the fasting glucose is high, then you could assume they're probably insulin resistant or metabolically unhealthy, but not all of them, but a lot of them are, the majority. And another marker is the triglyceride to HDL ratio, which we published a long time ago in the Annals in 2003. But when the triglycerides are high and the HDL is low, that's a very good marker that somebody has insulin resistance. And the cutoff that we published, just to make it easy for clinicians, is 3. And I always teach that to the fellows. It's not perfect, but it's a pretty good indicator. If you have a ratio of triglyceride to HDL cholesterol of 3 or higher, that you do have insulin resistance. So that's an easy biomarker, and it's a standardized,
Hmm.
readily obtained lab. So a lot of people have that information.
Hmm. How about
Hmm.
fat distribution? I know you've published around where the
Yeah.
fat's located might have an issue, have an impact on insulin resistance or so.
Yeah, I think generally people who are insulin resistant tend to have more upper body fat and more visceral fat. With visceral fat is the fat inside the abdomen. That's where most of your, most of the not subcutaneous fat's the fat right under the skin. So you can pinch an inch, that's your subcutaneous fat. And that fat's actually doing an important job, which is storing excess calories that you can mobilize when you're sleeping or fasted. The visceral fat probably has a very different biological function, and we're not really sure what it is. And we also, some people think it's sort of just an overflow depot for extra fat when you can't store it all in the right place, which is the subcutaneous fat. I believe it's probably serving a biological function if it's there. But when people gain weight, some people tend to put a lot of fat around the organs, and others just put it in the subcutaneous depot and they get more of that fat. So when people gain weight and they tend to put their fat around the internal organs, that group of people is more likely to have metabolic disease, insulin resistance. And with COVID, there actually are a couple studies, small studies, showing that visceral fat is a better predictor than total fat of severe acute COVID. So that kind of fits with this hypothesis that if you have a lot of fat around your vital organs and it's getting infected and inflamed, you might have a worse outcome.
Mm.
Can't exactly prove that, but those are some of the things that we think about.
Interesting. You know, we're hearing we're hearing so much about obesity now, and these new drugs that are coming out, these incretin type drugs that we're seeing like rapid weight loss in people, and you know we've actually had a session at the last scientific sessions where I think it was tirzepatide, for example, was this dramatic weight loss. So how does what does that do for obesity? What does that do for inflammation? What are the consequences of that beyond just kind of the weight loss?
Well, I mean, that's the million-dollar question. And all these studies that have been done with these great GLP-1 agonists mostly have looked at weight loss, right? These large clinical trials, they look at weight loss, and some are looking at liver fat, looking at clinical markers like blood pressure and lipids. We don't really have much data on what it's doing to inflammation or inflammation in fat or even fat distribution right now. So I think that what I believe is that weight loss per se is probably the most important thing. So if you can lose a lot of weight, you're going to have metabolic benefits. But what's interesting is to think about how these drugs might actually specifically address these metabolic factors that are related to excess body weight. So, inflammation in the fat or disordered fat storage, where it's going to surround the organs. So, visceral fat, epicardial fat, um, and insulin resistance. And tirzepatide in particular is interesting because tirzepatide is a dual agonist, right? So it's a GLP agonist and a GIP agonist. And GIP actually binds the fat. There are receptors for GIP in the fat. So we don't really know what it's doing, but a lot of biologists are quite interested to see how it might directly improve metabolic health through some action on the fat. Um, but but these drugs are amazing, and I think they're certainly have been shown in large trials, like Saxenda was shown. That's liraglutide at the 3 milligram dose to reduce the risk of progression to diabetes by, I think it was 70% in people who had impaired glucose tolerance. So they're pretty powerful tools for improving metabolic health, at least with regard to glucose.
Fascinating, yeah. I know we're running short of time, but I have a question. Another question for you is that we have people with type 2 diabetes who are not obese. Um, and so
Right.
what's going on there? Is there
Mm.
inflammation going on there, or what's causing their diabetes? This again, people that are they're not having this kind of uh,
Right.
obviously obesity from issues, and so
Well, that's really important. There are a lot of normal weight type 2 diabetics, and I think that there are maybe a couple of factors at play. Now, some people are interested in sarcopenia, and that's not my area of research, but there are people who are looking at whether low muscle mass might be contributing to that because insulin mediated glucose disposal is occurring mostly in the muscle. So if you had low muscle, maybe you got, low, little insulin resistant. But what we've shown is that those people who have prediabetes or diabetes who are normal body weight, a lot of them are really insulin resistant. And in one study, we showed that they had all the same things, the whole metabolic syndrome factors. I don't know if we looked at inflammation per se, but what we showed was that when they lost weight, they responded just as well as an obese person who lost weight. So if I think in a normal weight diabetic, you always want to think about making sure they don't have autoimmune diabetes because, right, that can happen at older
Yeah.
ages. And there's a lot of overlap now with type 2 showing up at young ages and type 1 showing up at old ages. So you should probably always check for that if you're a clinician or if you're a patient, make sure they rule it out. But if you don't have type 1, which you can detect by autoantibodies, a lot of those people are just going to have the same old metabolic disease, insulin resistance. They're just getting it at a lower threshold.
Oh,
And that's what I'm saying. Like I call it the tipping point, but some people can handle a lot of excess body weight and stay metabolically healthy. But if you keep pushing them, they're probably going to get insulin resistant eventually. And likewise, there are some people whose bodies just really can't handle even a little bit of extra body weight. And they get pushed over into this insulin resistant metabolic syndrome state. But weight loss can reverse it to some extent, which is great. I think really important to remember.
fascinating. So this, what that underscores is so much heterogeneity there in
There's,
terms of the population, in terms of diabetes.
yes, there is a lot of heterogeneity. And I know that is a big goal of NIH right now and something we're looking at as well. But we have insulin resistance that can, I mean, the way we define diabetes is actually interesting because it's all based on glucose. So if it's high enough, you're diabetic. If it's a little high, you're pre-diabetic. And if it's low, you're normal glycemic. But there are many pathways that lead to glucose dysregulation or glucose elevation. And we've been talking about insulin resistance, but beta cell dysfunction also leads to high glucose. And now we know that the incretin hormones, which is the GLP, which is secreted by all humans, we make it ourselves, you don't have to take a drug to get it, that might be defective in some people, leading to high glucose. So there may be many different physiologic pathways to getting a high glucose, which might explain some of the heterogeneity. So you got some people who are healthy and some who have one or another, pathophysiologic defects. And I think in the next decade, we're really going to be focusing on the heterogeneity a lot.
Fascinating. I think there's so much research that needs to be done to understand the heterogeneity among the population and how best to address diabetes in the various subtypes and so of people that have it. This has been an absolutely fascinating discussion, and it's so interesting to hear about your work and the aspects around obesity and inflammation and diabetes and insulin resistance. Thank you so much. This has been very, very informative.
You're welcome. It's been an absolute pleasure.
Thank you so much. And thank you so much for the work you do here, also too with the ADA funding that provided. It's excellent.
Very appreciative of that.
Thank you.